Great, thank you for coming. My name is Tim Jeans. I'm a regional manager with a company called Advocate Health. We specialize in Medicare and in Medicare plans. So what we're going to do today, specifically though, is just an overview of the Medicare program. So what's Medicare Parts A, B, C, and D, and cover that whole gamut. This goes pretty quick, so I'm not planning to take an hour and a half. I don't want to put anyone to sleep. But what I would welcome though is, as I'm going through, if you have a question, feel free to stop me in the middle and ask the question. I'd rather you do that than try to wait to the end and then maybe you'll forget your question. I'd rather try to get you an answer if I can. So, but it's great to be here with you. I'm responsible with Advocate, I handle all of the West Coast and a couple other states, so I tend to travel a lot. I love it when I can work in California because it means I just jump in the car and drive where I'm going. You don't have to get on an airplane. So it's very nice to be here today because this was just a car drive. All right, so Medicare. We're going to talk about Medicare 101 and some of the basics. Let me just jump into it. I'm going to start with a question. So how long has Medicare been around? Does anyone know? Quick test question.
65.
Who said 65? You're right. It's been around since 1965. Not exactly a new program. It's been around a while. If you happen to have Medicare or know someone that does, you may have noticed about a year ago you got a new card. And the reason for that is the previous card, what we used to use, your Medicare number was actually also a Social Security number followed by an A or a B, or sometimes another letter. So just because of issues with personal information being stolen or just the risk of it, you got a brand new Medicare card which has a number that no one is going to remember. It's a very long combination of letters and numbers. It's probably a little bit more secure. It makes sense. So a little bit of history, just real briefly. So Medicare began in 1965, and you can see here President Lyndon Johnson signed it. Does anyone recognize the gentleman over on the right side of the screen? It's not a great picture of him, and it's from the side, right here. Previous president. That's Truman, that's Harry Truman. And actually, he's with his wife, she's in yellow right next to him. President Truman was pitching the idea of Medicare in the 50s, but he was never able to get it across. So he and his wife were present, invited to be there when President Johnson signed Medicare, the bill that included Medicare, into law. And actually, President Truman and his wife were the first Medicare beneficiaries. The premium they paid was much less than it is today. Much lower than it is today. But, so I think he deserves a little bit of credit for having encouraged the idea and tried to move that legislation along. So it's been a law for many years. And Medicare enrollment, just Medicare in general, just due to our own demographics as a country, has been increasing dramatically. So you can see over time, you go back to 1970, there were about 20 million Americans, a little over, that were receiving Medicare. And that number has never turned back, right? It's continuing to rise. The projections are enormous. I mean, we're only, 2020, hard to believe, is only, it's what, a year away? Not even a year away. We're almost there, and that projection's pretty close. Believe it or not, there's between somewhere around 10 to 11,000 people turn 65 daily in the United States. So that trend will continue. There's some interesting things when I was just doing a little bit of research, is that when Medicare started, so back at this point in time, I don't think they had any idea of what the future held. In the early days, when we were looking at Medicare, you consider life expectancy in the 60s, I believe for males in the United States, I think it was somewhere around 68 to 69 was the average lifespan, and for women a little bit longer. But so what they were looking at was typically around 8 to 10 people that were working for each person that was receiving Social Security and Medicare benefits. It was a very easy sell, and it made perfect sense. And if you figured on average, the average Medicare beneficiary would be receiving the benefit for, maybe 3 to 5 years. It was pretty easy to see how this program could float with no problem. It's changed, though. It's changed pretty dramatically. I'll use my own family as an example. My grandmother passed away at 97. So she collected benefits from Medicare and Social Security for a very long time. And she's not alone in that, right? And with the changing of demographics, now it's about 3 people working for each people receiving a benefit. So if you're wondering, why does my Medicare premium keep going up? If you've seen that, or if that's even a reality for you, that's part of the reason why. There's been a pretty dramatic shift from how it started of how many people were paying as compared to beneficiaries. So it's something we'll have to, the federal government's going to have to work that out over time to figure out how to keep it going. Because Medicare is a pretty fantastic program. So let me jump back. So there's 4 parts of Medicare. They're pretty creative. I bet you can guess the following 3 just based on what you've seen there. There's A, hospital. Anyone know what the other parts are?
B, C, D, I.
Yeah, you got it.
Hospital, doctor, and drug.
You got it. You got it. Very creatively named, right? Parts A and I'll start with this. Parts A and B are provided by the federal government directly. All right, and you enroll through Social Security. So typically what happens is this, with Part A, when we're working, we're paying into Medicare Part A, into the funds for that. So for most people, when they get to Medicare eligibility, there's no cost for Medicare Part A, because in essence, you've been paying for it as long as you've been working. It comes out of your check. Part B is also about 75% of Part B comes from the federal budget, and about 25% comes from the Part B premiums that we pay when we have Medicare. So it's a shared cost. But they're both provided directly through the federal government. Part A in general covers hospital costs, while Part B covers medical. The 2 newer ones are C and D. So now there's 4 parts of Medicare. C and D are provided by private insurance companies, and you can choose the one that you want. So you could do either or, depending on what your needs are, what you would like. So A and B provided directly from the federal government. Parts C and D, obviously it's part of the government program, but it's provided, the services would be provided through a company that had a contract with Medicare to offer either what's called a Medicare Advantage plan or a drug plan, Part D. All right, so you've got four parts. The key to all this, though, is you need to have Part A and B to have options with the others. That's kind of your ticket in, having Part A and B. All right, who's eligible for Medicare? Take a quick look, and I'll read it just in case it's tough to read in the back, because I couldn't read this from the back. So who's eligible for Medicare? A would be someone age 65 and paid into Medicare for at least 40 quarters, which is 10 years. Or answer B, age 65 and paid into Medicare for at least 20 quarters, 5 years. Or C, under age 65 and have been on Social Security disability for at least 24 consecutive months. Or it could be a combination. Any ideas? A and C? You are right. Awesome. That's exactly right. So age 65, paid into Medicare for at least 10 years. Another common way is age 65 and married to someone who worked for at least 10 years, 40 quarters. So you get it either way. Because you got to remember, I mean, when we think back to the 60s, it was pretty common that households were one wage earner, correct? Well, there had to be a way to make sure that the spouse had access as well. So it's through working it yourself or through your spouse. And C, that started a little bit later, but that's also been added. So if someone's been on Social Security, and that's the key, Social Security disability, which is a process in and of itself, but if someone qualifies for Social Security disability, then after 24 months, they're automatically enrolled in Medicare. That's how that works. All right, jumping in. Any questions so far? We're doing okay? Can you hear me all right? All right, good. All right, so let's talk about Medicare Part A. It's typically premium-free or no premium because you've been paying for it your entire working life. It's one of those tax deductions that comes out of your check. What does it provide coverage for? Primarily inpatient hospitalizations and skilled nursing. All right, in addition to that, home health care, and I'll explain that in a second because it's a narrow definition, and also hospice. So those are the four things that primarily fall underneath Medicare Part A. So anything to do with being in the hospital, and what's interesting about this, if you look, you can see there's skilled nursing and home health care tend very commonly to be attached to or part of hospitalization. So maybe after a surgery or some type of a procedure, sometimes skilled nursing is necessary to get the patient up where they can be comfortable and safe at home. And after that, depending on doctor's orders, home health care might be necessary. Home health care, I want to be careful to describe that. This does not cover activities of daily living. I don't know if that sounds familiar, it might. Activities of daily living are things like dressing, washing, eating. Medicare doesn't cover that. That would require a completely different type of insurance policy called long-term care, which is completely different. All right, this would be if a doctor says, yeah, we're gonna need someone to go in, maybe do a little therapy, changing bandages and things like that. It's intermittent. Yes?
So if you're in the hospital, you had a stroke, I'm asking because I'm living this with a friend's mom.
Okay.
They put her in skilled nursing to try to rehab for 3 weeks, and then decide they're kicking her out and sending her home.
Okay.
She can't walk, and they claim they're not gonna cover a wheelchair, a walker, a bedside commode. Who pays for that?
Does she have Medicare?
Yes.
Okay, that's actually sounds very strange because a doctor can write a prescription for durable medical equipment, which is covered.
Her insurance is refusing to cover all these things. Refusing to let her stay in the hospital till someone can be home with her, these kinds of things. But that should all be Medicare A, right? Inpatient, skilled nursing?
It is as long as a doctor writes the prescription. As long as the doctor writes a prescription, they can get those benefits.
Then maybe that's where it all fell in. Okay.
That would be my guess. I don't know for sure, obviously, but it sounds to me like what you're describing is, well, when we don't get to choose when they send us home from the hospital or skilled nursing facility, right? There's, whether we agree or not, they'll make a determination. It's usually the doctors that determine that. I had an experience with that myself. I'll tell it because it's quick and it's personal. I had my first surgery forever. It was simply an appendectomy. So big deal to me though. I'd never been cut open, so it was a big deal to me. All I remember is that when I woke up after I came up from out of the anesthesia, I was still a little bit groggy, and I just remember someone tapping me on the leg and saying, "Okay, time to wake up. It's time to go home." And I remember thinking, "Time to go home? I can't even sit up. How am I going to go home?" So fortunately my wife was there. She can't pick me up or carry me, but they gave me a minute or two to compose myself, and then I was wheeled outside, and my wife grabbed the car, and they helped me in the car, and I went home. So I was a little bit offended because I thought it needed at least another half an hour, 45 minutes to wake up. But I get it. I think they want the beds and they want the space, and once I did get home, I was glad I was actually resting in my own bed. But it's kind of interesting what happens, right? There's a whole process. They want to move us along. They want to keep us moving. With home health and hospice, those are things that if a doctor writes a prescription, that tends to be honored. So maybe that's something to look into. I don't know who's managing the care or the primary doctor. They need to step up, would be my guess. All right, so what happens if all you have is Medicare? Because originally, for most folks, Medicare was fine all by itself. Because back in the 60s, even into the 70s and 80s, to go see a doctor wasn't really costly. It was the hospitalization that was scary. Right? That's what would break the bank, would be hospitalizations. And so Medicare had a formula of what they would cover for hospitalization. This is how it works today, all right, for 2019. So these amounts obviously are definitely much higher than they were originally. They go up every year. So let's say all you have is Medicare, no other insurance at all. Well, when you go to the hospital, your first 60 days in the hospital, you have a deductible of $1,364. And that will cover your hospital room and hospital charges. So it's a little bit pricey. It's not terrible. There's some plans out there that have pretty high deductibles. But so this is what now if you're in the hospital for an extremely long time, and this is becoming a little less common, the deductible covers the first 60 days. If you're in the hospital over 60 days, between 61 and 90, then you have a per day copay, and that's $341, okay? After 90 days, you dip into what's called a lifetime reserve day. Medicare gives everyone 60 lifetime reserve days. So as you use them up, they're not replenished. You're at 60 total. And to use those days, it's double the $341. Now it's $682 per day. And if you're in the hospital over 150 days, then you're on the hook for the whole amount. That's pretty unlikely. But this is how Medicare by itself works. All right. So you can see there are some costs, pushed over to us. That's all cost. I can say, as a means of comparison, one of the plans I had through my former employer, I had what's now very common. It's a high deductible health plan. You may have heard those, HSA, with a health savings account. My family deductible was $5,000. And that's what I had to pay before the insurance kicked in. It happened to fall just around that time when we decided to start a family. So we hit the deductible every year. Every year. So I was paying the $5,000, and of course I couldn't write a check for it, so that's when I call the hospital and I get a payment plan, and we divide it up by 12 months and I write a check every month. That has become fairly common. So, the $1,300 deductible isn't as terrible as it sounds, but it's a lot. And if you're on a fixed income, which I would say most of us are on fixed incomes at age 65, that's pretty common, so then those dollar amounts become pretty critical. All right, the next portion is that skilled nursing facility, where that's sometimes the process. You finish treatment at a hospital. The hospital doesn't want people in a bed being rehabbed. They can't afford that, and so they want you out. And that's when a nursing facility comes in. That's where the therapy and things like that will take place. It's a little bit less costly than a hospital, and it frees up the hospital for emergencies is the idea. So with skilled nursing facility, the first 20 days, remember, this is just under Medicare, if you've got your Medicare Part A and B. The first 20 days, you don't pay anything. All right, so your first 20 days are covered, and that covers very high percentage of stays at a skilled nursing facility. They can go longer, but they normally don't. And if an individual goes over 20 days, they have a copay, $170.50 per day. But after 100 days, if they still happen to be there, then Medicare no longer pays. All right, so that's the cutoff there as well. And by the way, all this information can be found, and I apologize, this may not be easy to see. I'm going to show you the website in a little bit. Medicare.gov is a fantastic resource. A lot of times when I'm asked questions about Medicare plans, I just go to Medicare.gov. It's a very useful website. It's pretty well done. All right, hospice care, covered 100%. It's kind of nice. I mean, if you or a loved one is in that situation, it's kind of the last thing you want to worry about are medical bills when you're trying to deal with that. And then of course, home health care, it's covered if it's Medicare approved, which means, and that's where the doctor has to write a prescription and send it in. All right, and then Medicare makes the determination. All right. I'm gonna throw in a little bit of a joke. Okay, let's lighten this up. This is heavy stuff. All right. Expensive care, he wrote on the door. I hate to tell you this, but that should be intensive care. All right. True or false? Does Medicare have an annual max out-of-pocket limit? First, should I explain? Did everyone know what an annual max out-of-pocket limit is? All right, that is a term that insurance uses for when a beneficiary reaches a certain amount that they do not have to go beyond. So, for example, a plan might say, okay, at $5,000, you're done, your medical expenses will be paid 100% the remainder of the year. That's what a max out-of-pocket limit is. So it's something designed as a protection against catastrophic loss to the insured, is what that is. So does Medicare have an out-of-pocket limit? Is there a cap?
Yeah, well, I think I read an old book, 2016, I think they said it was 9,500.
It could be on it. It sounds like that might be a private plan.
Oh, okay.
For a number like that, that would be my guess. And actually, Medicare does not have a max out-of-pocket limit. And the thing is, when Medicare came out, no one would have even dreamed it would be necessary because medical costs at the time, the only thing that was breaking the bank would be an unexpected hospitalization. It wasn't, to go to the doctor wasn't really nearly as expensive as it is now, not even close. Of course, technology's changed too, right? All right, so let's talk about Medicare Part B. This is the other half of the original Medicare program. All right, so standard monthly premium in 2019 is $135.50, which in almost all cases is a deduction from a Social Security check. That's typically where it comes out, okay? That amount goes up over time. I thought I heard that President Truman, when he got that first policy, I think his share, monthly for Medicare was more, I think it was in the teens. I think it was like $15, $16. I don't know what that is in today's dollars if you adjust for inflation. Probably more than it sounds, but it was definitely smaller than that. And there's also, for Medicare Part B, there's an annual deductible. So the amount that we have to pay first before Medicare kicks in. That deductible, though, is actually pretty small by today's standards for private insurance. It's $185. And then Medicare kicks in. And we say standard monthly premium because I'm trying to remember when this passed. It was probably only 4 or 5 years ago. It has not too long that the government passed a tiered system for Medicare Part B premium. It used to be that everyone paid the same premium. Now it's based on your income. So if I'm not mistaken, I believe if you're on Medicare and you as an individual make over 80-something thousand, then you're going to start paying higher than that. And as a couple, if you're making over 120 or 130,000, you pay more. So it's not everyone pays the same premium anymore. As your income goes up, your Part B premium will go up. The deductible will stay the same though. Now, after the deductible, traditional Medicare is what's called co-insurance. You share the cost percentage-wise. Medicare will pay 80% and the beneficiary 20%. Right? Kind of sounds like the typical PPOs that were around forever, private PPOs, where you'd share the cost 80-20. That's how Medicare worked for quite some time. And for decades, it was perfect. It was fine, because if you went to the doctor and their bill was $20, well, if that's what Medicare allows, well, then you pay 20% of that. All right, we're not talking, it's about $4, right? So pretty reasonable. The other thing is the 80-20 is based on what Medicare determines is customary and reasonable. So the medical providers don't get to choose what they're going to charge you. All right, that's one of the protections I think sometimes we forget that comes with Medicare. Providers can't charge you more than what Medicare allows, except in very specific circumstances. All right, and what Medicare allows is not what the hospital charges. I don't know if anyone's ever seen a hospital bill, or you get a hospital bill after and you see what they're charging for, and then you see what the insurance company paid on your behalf, and it's usually a fraction. I don't know how the math works. It's a little crazy, but that's a protection to anyone that has Medicare. The providers cannot charge you more. There is something that you should know, is that doctors are allowed to do something, I believe it's called balance billing, where if a doctor tells you up front, look, I don't take Medicare, not interested. If they tell you that, but are willing to see you, they can only charge 15% more than what Medicare allows. So they're capped at 115% of Medicare allowable. So, but by law, they're supposed to tell you first. You're supposed to be notified, look, we don't take Medicare, we will see you, but we're going to balance bill you. You're going to get billed the additional 15% if you really want to come here. For most people, that's enough to say, no, it's okay, I'll go find someone else. Could be, I know for my dad, for example, he did want to see a particular specialist, a neurologist. He was willing to pay the extra 15% for who he was able to see. So that's just a personal decision. Yes?
Do they cover chiropractic?
In general, no. No. Medicare doesn't like to move too far out of the standard medical billing. Okay, covers almost all reasonable necessary medical services. And now remember, but Medicare chooses, and it's pretty much up to a doctor, you know, to be asking for, to be putting in the request. So doctor services, labs and x-rays and so forth, ambulance services, emergency room. It's kind of funny, they'd be like, wait a minute, emergency room. Part A covers your hospital stay. It's Part B, you're paying the 20% of everything up until such time as you're admitted to the hospital. Part A literally really just covers the hospital bed and the room and basic nursing services. This is something that sometimes it's easy to forget until you get the bill. So if you go to the hospital, you know, go through the emergency room, you know, the ambulance, then the emergency room, you're hospitalized for a few days, they do lab tests and x-rays and all those kind of things. Here's how it works. With Medicare, your deductible pays for the room that you're in, the lovely bed and the wonderful food. What Part B pays for is everything else. So when a doctor comes to see you and they run a lab test, you pay 20% of the lab test. That's not included. You pay 20% for the ambulance, for the emergency room. So for anything that's done outside of the hospital, and most tests these days are not done by the hospital. They're typically medical groups that work in the hospital. We don't see the difference as a patient, right? We just see, I'm in the hospital, I'm getting medical services. But individual medical groups, so the radiology is going to charge separate, right? The CAT scan or the lab tests, they all have their own charge. And so we would be responsible for the 20% of each of those.
So even the surgery that's done in the hospital, that's you pay, that's under B?
Yeah, so you better bet that the surgeon is not going to allow their services to be covered by the hospital. They will charge directly. They will. Yes?
I found out that the hard way because after my brother died, about a year later, I started getting all of those bills from all these different things. And if I, you know, I didn't have much to go on to find it, but
I'm sorry. I don't remember exactly how that works, but then again, I don't believe you're under any legal obligation. Or did they try to make it small?
well, no, the attorney said that since I had to do probate for him, that I was, so I had to meet with the hospital people and I said, look, I
They're
don't
going
feel
after
like.
the estate, basically, in a sense?
What was that?
Were they like trying to go collect from his estate, in essence,
Yeah.
maybe? Is that what? Oh.
And I said to him, I said, look, you know, why was he put in a private room when he had no insurance apparently? And
Very good
so
question.
I argued all these things with him, and then I got it reduced by about 75%, but I still ended up having to pay his bills. But I didn't feel that they were right in running all the stuff that he didn't need and giving him the most expensive stuff, knowing he had no insurance.
Wow.
And that's what they did.
You did the right thing by questioning, and that's something that I always advocate for, is always feel like you can question. I think
Well, I had to, he had no money. It was like.
so. It was without it, you had no choice.
So I was like, well, that was in, yeah, well, we're talking hundreds of thousands of dollars.
I'm sure it was. I'm sure it was. Thank you for sharing that. Yeah, there's definitely questions. You have every right to question a bill or to question a diagnosis. I think sometimes we forget that we have the right to question and ask or get a second opinion or say, is this bill right? Because I'm not so sure. I think sometimes we feel like we're conditioned to just do what we're told, you know, when it comes from, you know, a medical professional or facility. So, I mean, it's good to listen, but at the same time, it's also good to question for yourself, right? To take charge of some of that and ask questions. All right. This is where outpatient services and durable medical equipment is covered. All right, so and going back to your question, so with durable medical equipment, which covers a lot of things, they're typically Medicare, if they get a doctor's prescription for it, it's an 80-20 cost share, all right, of what Medicare allows, which is already going to be a be a discount over what they would try to charge the general public. All right. Services not covered by Medicare. This is probably just as important, maybe more important than what is covered, so that we know what to expect and not to expect. Custodial care is not covered by Medicare. Custodial care or activities of daily living, Medicare never has and never will cover that. Okay, typically that has to fall under a long-term care policy. Hearing aids and hearing exams, Medicare typically does not cover those things. Routine eye care and eyeglasses, they won't do that either. There's one small exception. They'll help you with eyeglasses, standard frames, nothing fancy. There'll be this one little area over here that you'll get to pick out from, and it's only after cataract surgery. All right, so it's quite limited. Most dental care and dentures will not be covered by Medicare if you really don't have dental coverage. And healthcare while traveling outside the United States, because it's a national health plan, right? So you need to be within the United States. It says, and it says this everywhere, except in limited cases. I have yet to have someone to explain to me what one of those limited cases would be. I honestly can't get an answer. I have no idea. I mean, maybe if you just stepped over the line into Canada or Mexico, maybe, I don't know. So I don't know what those, so just figure, if you're outside of the United States, you may want to purchase travel insurance before you go if you wanted the extra protection. All right. How to enroll? Any questions before I go on? So that's part A and B. Everyone doing okay? There's cookies, and so if you need sugar, there's cookies back there, and there is water, so please feel free to help yourselves. All right, how do you enroll? All right, just like that. It's that simple. Actually, it's for most folks, it's pretty simple. You're going to start getting information in the mail a good 3-4 months before you turn 65. And in general, what will happen, let me just jump forward. So, in general, what happens is this. Has anyone been through this? And you don't have to share if you don't want to, but if you've been through it, you know you get a lot of information in the mail. Medicare Part A typically comes at no charge, if you've worked at least 10 years. And then Part B, typically what they'll do is they'll just enroll you in Part B, and you can decline it if you want. So if you're still working, you're like, no, I don't want to pay the Part B premium, I'm covered through work for a little while longer. You can decline Part B. But in general, it's just sent to you. The government assumes you probably don't want it. Yes?
I haven't been getting anything really in the mail other than commercial people.
Okay. Nothing from Medicare yet?
No, not really. Maybe a card or something, a postcard.
Okay.
But nothing explanatory. Went to the website and I found out how many hoops I had to jump through, especially having had been on Medicaid for a while.
Okay. That shouldn't stop it though. Medicaid shouldn't impact your accessibility to Medicare.
I have an additional complication that may be coming up just simply because of the political environment today.
If you're coming up on 65 and you haven't received anything, what I would suggest, you probably want to actually call 1-800-Medicare, or maybe actually or call or go into a local Social Security office and have them pull up your file so that you can see when you're eligible. And I would ask them directly for that though, if you haven't received anything and you're coming up quick.
I know I have all my information correct to Social Security.
Okay.
I have a name change, so I don't know if they're having trouble tracking me down.
Yeah, it's possible. You might even want to go into a local office where you can sit down with someone and have them do that research.
And I don't know if they're getting enough federal facilities. I don't have a real ID.
Okay. Gotcha. I don't know.
Application and getting that too.
Sure.
I'll talk to you later about it.
Okay. I'm not sure how much I can help with that though. Getting out of my expertise for sure. All right.
Excuse me?
Oh, sorry. Yes.
Where's the local social security office?
The closest one here, I don't know what the closest one is here.
Hayward.
Paul, any idea?
Hayward.
Hayward's the closest?
I don't think Hayward would be the closest.
Okay. Yes.
You said if you're still working, you can decline Part B. Should you decline Part A also, or does it matter if you get it anyway?
No, well, there's no need to decline Part A because with Part A, there's usually no cost, so there's no impact. It doesn't hurt you at all. What typically happens with Part B, I mean, a lot of folks tend to work past 65, and sometimes, the insurance you get through work might be might be what you want, you don't want to change it anyway. So you can decline Part B so you're not paying that $135 a month unnecessarily, because Medicare allows you to enroll in Part B later on when you leave your group coverage. So it saves you the money in the meantime. So this is the major enrollment period with Medicare. It starts the first day of the month. The third month, so basically this, so I'll use myself as an example. My birthday is in April. So when I get to 65, I will be eligible for Medicare April 1st. It's probably kind of funny, it's April Fool's Day. You can see what it looks like when I get there. So what that means then is this initial enrollment period for Medicare for me, and so this is the way you do it, 3 months before the month of your birth. So in my case, January, February, March. April's my birthday month, and then May, June, July. So there's a 7-month period where you can enroll in, where you get enrolled into Medicare, and then during that period you can pick any additional Medicare coverage you would like. Whether it's a Medicare Supplement, or Medicare Advantage plan, or a drug plan, that's where you can enroll in whatever you'd like, and there are no health questions, there's no underwriting. All right, so it's kind of a nice period where you just grab the plan you want. You may be aware of people, you may have friends or family that were waiting to get there because maybe insurance was difficult to find. My dad was in that position. He was waiting to turn 65 because he and my mom had been, they were self-employed for decades. They didn't have a group health plan. And as you probably know, when you get into your 60s, an individual health plan is really expensive. It's really, really expensive. So he actually just simply didn't even purchase one. He just paid as he just self-insured for those years. And when he turned 65, got Medicare and a Medicare Supplement and the drug plan, and it changed everything. It dramatically reduced his costs. So this is a pretty important time. All right, so that's, probably I explained it before I showed you the graphic. That's what it is, all right? So figure your birthday in the middle and add 3 months to either side, and that's your initial enrollment period for Medicare. All right, special enrollment period. Medicare does have their major special enrollment period, as we talked about, is if you're staying with your employer group plan. It could be a retirement plan, or maybe you're actively working and you're on the group plan. You can decline Part B, so you're not paying double, right? There's no need to pay for Part B if you're already covered. And you stay on that plan, and then when you think you're ready to either leave the group plan or retire, you need to remember to get Medicare Part B within 8 months of dropping that coverage, or you're going to get penalized. So it's not as scary as it sounds, because I'm pretty sure that if you're dropping your group plan, you're not dropping it to go to no coverage at all. You're going to be looking around going, okay, what am I going into? And you're going to want your Part B at that point.
Now, the point is there a period for C and D as well?
Yes, there are, and I'll get to those in just a second. There are. Yep. Okay. General enrollment period. All right. Hopefully, you never need to use this. And I'll tell you why, because this is only if you're getting penalized. So let's just assume that I decline Part B because I'm covered through work. And then a couple of years later, I decide I'm going to retire now, and I completely space the fact that I'm losing my group coverage and I don't enroll in Medicare. If I go longer than 8 months without enrolling in Medicare Part B, I'm going to get stuck. I'm going to have to wait until the following January. And between January 1st and March 31st of each year, they have this general enrollment period where I can then enroll in Part B, but it will not become effective until July 1st. They're going to make me wait. That's part of the punishment. And the other is I'm going to have a 10% penalty for every year that I went without Part B. So that 135 they'd add another, what, $13.50 for the rest of my life. So I'll pay 10% more than everyone else for the rest of my life. So you don't want to miss out enrolling. Yeah, you don't want to miss out enrolling in Part B when you're supposed to. So you always take it when it's available. Okay? Did you have a question?
Well, no, I was just kind of going back to that penalty, because my mother had never signed up for Part B because she didn't know. And so when she had a stroke, like in her 80s, there was 20-something years that went by that you have Part B.
Oh,
And this penalty thing, I thought, they said you had to pay 10% for every year.
correct.
So was that just for 1 year, or I was figuring it by a month that was coming out?
They just round to the closest year, so if it was 20 years, 200%.
Yeah, I was trying to figure out how to see if I could go ahead and pay it, because I was paying her nursing home
Oh,
it was like $5,000-something a year, or
right.
a month.
A month.
And I thought, well, would it be better if I tried to go back and pay that, because she did last a lot longer,
Okay.
almost another 20 years. So it was like, I just really didn't know, because they didn't explain it to me very well, but it just sort of seemed like it was astronomical to pay
It would have
that
been in that
upfront, and
case.
then maybe it would have been better off in the end having done that, I don't know.
Okay, just to keep the costs down, to pay the
Yeah,
additional
that's-
200% for the Medicare and get those benefits.
But that 200% wasn't a one-time thing, it was like, maybe it wasn't.
It's every month. Yes?
Okay. In summation, does this mean I have, during my regular enrollment period now, I have to select a private insurer or C&D immediately?
You don't have to, that's up to you. But you do want to make sure that you get at least some type of Medicare drug coverage, so that, because that has a penalty as well. And I can show you that in a
But
moment.
that's a private insurer, right?
Yes, but the federal government will impose a penalty if you don't elect one.
Oh, great. Then what happens what if I change my mind? I decide that Kaiser's not for me?
Every year, you have at least one time to change and get out of that plan. You're never locked in for more than 12 months
I
max.
hate to be locked into a bad insurer.
Yeah, you have at least one chance every year to change. So it's kind of like during the working years where your HR department lets you make a change every year. It works kind of like that. Yes, sir.
So, in qualifying for that initial payment, it's like your income for 2 years prior to that, where they determine what your premium for Part B is going to be, whether it's 135, if you need more money, then you would be paying more premium. Is that correct?
That is correct. I can't remember how far they look back, but they do
How is
look
the penalty, I think it's 2 years,
2 years. Okay.
how is the penalty assessed? Is it assessed on the higher amount that you're paying, or is it at the 135 level?
I believe it's actually assessed on the amount that you're required to pay.
So if you're paying $185 a month,
It'd be on that.
it would be based on that.
Yes. Yeah.
Quick on the payment on Part B. My mother keeps telling me it's just normally taken out of your Social Security.
Yes.
But
In most cases,
here's the
that's
trick. At my age group, we don't get Social Security for yet another year.
right. So you have to set up an alternate method of payment. And, we would take it from your checking account or your bank account, or set up, use some type of payment.
Or take Social Security yearly.
You could. It's not usually recommended to take Social Security early though, because it does reduce your benefit amount.
About $50 a month.
Yeah, it does have an impact. It may be preferable to just set up an alternate payment method, during that time that, while you're not collecting Social Security.
To say that my pension plans are complicated, so I understand.
All right, so Part C. Now this is an alternative. Well, it's one of your options. Okay, so this is Part C. The difference here is that this is provided by a private insurance company. Part A and B directly from the federal government. This is private insurance company. So it's sold by insurance companies, sometimes called MA, Medicare Advantage, or MAPD, if you ever heard those terms. MAPD just means Medicare Advantage plan with prescription drug coverage built in. That's what that means. If you purchase a Medicare Advantage plan, what happens is this. In the early days, when this first came out, I worked for a company called Humana, and we didn't know what this was. It was brand new in the early 2000s. So the big fear was, well, if I sign up for that, I'm losing Medicare. Well, we now know over time, of course, that's not the case, but what happens is you assign your Medicare benefits to an insurance company to manage. That's the relationship. So the Medicare plan, then you pay them a premium or if it has one, and then you get the benefits as stated in the plan documents. It's one of your options. But here's the key, you have to always pay Part B because that's what keeps you eligible. Someone that doesn't have Part A and B of Medicare can't get a Part C plan. All right, and here's where the protection comes in. A Medicare Advantage plan, Medicare requires that they be at least as good as basic Medicare, but they can offer extra coverage. Yes?
Here's the rub, I got my, she doesn't have to worry about it, she's triple covered under military, foreign slap, and Medicare.
Okay.
But me, she seems to stay away from Advantage, and because it's just gonna take not give you anything. She's saying that I should have some kind of like regular insurance. Is there an option like that at all?
Sure. So it depends on what you want. You'll have just as many people say they love their Advantage plan. They'll tell you the reverse. So it depends on the individual, but you do not have to get one of these plans. You could actually get Medicare and get a Medicare supplement.
Now, the supplement plans, you can explain those too?
So, yeah, we'll get that to just in one moment. So a supplement is a private insurance plan that literally supplements your Medicare. So you're keeping Medicare, and you get a supplement plan, and the supplements tend to help pay those deductibles and the 20% that Medicare doesn't. So when you go to the doctor or hospital, you show both your cards. And then Medicare pays their portion, and after Medicare pays, then the supplement will pay whatever portion, whatever portion that particular supplement covers. And they're standardized.
You can switch those things at the same time as the usual?
No, with them you can switch anytime, but once you've passed that magic 7 months, supplement companies will make you go through underwriting. They're medically underwritten. That's the difference. So, but if you have one and it's working, you just keep it.
No, the point is like conditional illness past 7 months, then you're kind of closed. You can't get an Advantage plan.
No, you could drop it and go to an Advantage plan if you wanted.
So you still have that thing you can drop it.
You do. The good news is that we've got now like 15 or so years of experience with all the parts of Medicare, the C and the D. So they've pretty much worked out a lot of the kinks. You do have options to go in or out of them. So you're never really locked in. Yes?
Is the difference then between the supplement and the Advantage is that the supplement helps you pay for the deductibles and companies, and the Advantage is an additional medical care? Is that the main difference?
Yeah, let me try to explain that. So let me make sure I don't jump ahead of myself. If the next slide explains it, I'll use that. Let me see here. Okay, so yeah, let me explain that. It's good to know the difference. So with Medicare, if I have my Medicare A and B card, right, and then if I decide, I want a Medicare supplement, because with the Medicare supplement, there's no network, there's no primary care doctor, you can go to any doctor in the country that accepts Medicare, right? So what you do, as long as you don't mind paying the premium, you get your supplement, and then every time you get a medical service, you show both cards, because both are paying, right? Medicare pays their portion first, they'll pay their 80%, for example, first, and then the supplement will step in, depending on the supplement you choose, they tend to pick up the other 20%, all right? So you got two cards, and they'll pretty much cover you, and then you just pay the premium for your supplement. The one thing you have to remember, if you get a supplement, supplements do not include drug coverage, and Medicare requires that you have a drug plan. So then you need to go out and just pick up, and in every area there's, I think, pretty much every county in California, there's at least 30 or 40 drug plans to choose from. There's a ton. So you get yourself a drug plan, so you have prescription coverage at the pharmacy, and then you've got your supplement and Medicare. So you've got 3 cards, you're gonna have pretty good coverage. So Medicare supplements literally supplement your original Medicare. And they do have a cost, okay? They always have a premium.
If you get an Advantage plan and you have a question with billing, do you have to go to the company, the supplement, not the supplement, but the...
Yes. So let me explain how that part works.
They take care of everything.
So Medicare supplement, then you get your Medicare and your supplement on top of it, right? They work together. Medicare Advantage is different, all right? With Medicare Advantage, so let's say I join, I'll use Humana, since it's a company I'm familiar with from the past. If I were to enroll in a Humana plan, Humana then would take over my Medicare benefits for me. My co-pays would depend on the plan that I got.
So you deal with them now?
And so if I had a question or I wanted to contest a bill or a referral, I would go to the insurance company and say, hey, I don't agree with this, and go through their process. And if I wasn't entirely happy with them, I could jump over, I could go to Medicare and say, hey, I need help over here. So it's two different ways to get your Medicare benefits to you, all right? So it's good to know the differences, because it's not that one is better than the other, they function completely differently. So depending on the person, what's best for you, it's good to know what your choices are. With Medicare Part C, one of the things that's very different is they typically do have a network of doctors. So if you're considering one of these plans, you want to know, can I continue to see my current doctors, or would I have to change them? Because these plans do have networks generally. That's different. With Medicare supplements, there's no network. As long as the doctor accepts Medicare, you can go. Right? So it's two different things for sure. Yes?
So the networks that you speak of, like as an example in this area, how do you go about finding the networks? I mean, is there a list on Medicare.gov, or like for Stanford or for Summit, or I mean, how do you find those plans?
Each insurance company will have a provider search. What I would do is I would take a look at the company's website. Let's say Medicare.gov will tell you who's in your county, right? So they'll give you the list of names of the companies. You could then go to those websites and go, okay, I'm going to just drop in some doctors' names. I'm going to see who. And typically what you can find then is you can look up doctors and see if they're in the network or not. The other thing you can do, talk to a licensed agent that works in the Medicare field that can answer those questions, or go to the company and get those answers for you. Because every company is going to go out and negotiate, different contracts. Same thing, like probably similar to the plan that you might have through work, right? There's certain doctors that you tend to go to because that's who's in the plan. It works the same way. So either company website to look up doctors, or ask a licensed agent that's certified by that company so they can go get the information for you. That's really important, that if your doctors are in the network of the particular company you're interested in, it may be a nice option. If your doctors are not in the network, then that's a very different situation. You have to decide, well, do I want new doctors, or would I rather just get something else? What they tend to do though, there is a cost. The cost to us would be, okay, I don't have almost every doctor, now I have a network. That's, in essence, kind of a negative, but what's the positive out of it? Well, there are some positives. What it will do is it will take your costs and make them much more predictable. So most of these plans have fixed co-pays for everything, so you never have a surprise. That's the idea, so you know, okay, if I see my family doctor, I pay $10. If I go to a specialist, it's $35. I'm making up numbers, of course. And if I go to the hospital, it's X number of dollars per day. So what Medicare Advantage will do, they might have a limited network, but then what they'll do is they'll give you some predictability, where here's your co-pays, this is what you're responsible for, and that's all you're responsible for. So it's predictable if that's something that's important. They also, over the years, because they've had 15 years to practice, they've figured out what they can include. And most of these plans look very different now than they did 10, 12 years ago. They're far richer in benefit than they used to be, because now they have some experience to draw upon. So most have wellness programs, will include routine hearing, vision, dental, fitness memberships. There's typically a lot of extras as the draw for why you might want to join a plan with a network, right? And then you just have to decide if that makes sense for you or not. Now, they have their own enrollment periods established by Medicare. So the good news is with these plans, you're not stuck. You have at least one, usually more than once a year, where you can make a change if for some reason you go, this is not what I thought I was going to get. You can then change. You're not stuck. You never are. So these are initial enrollment period, which is the same as Medicare's initial enrollment period. That's 7 months around your birthday, turning 65. They also have something called the annual enrollment period, which is coming up in October. and you'll probably know it because you're going to see a crazy amount of advertisements on TV and radio and in the mail. Annual enrollment periods, we see it has the date. If it doesn't, then I'll just tell you. Annual enrollment period is October 15th to December 7th. So that's the magic open period where every year the whole Medicare world gets to make a choice if they would like. All right, and then your new plan starts January 1st. There's also some special enrollment periods, one that I'm really happy they brought back. There's something called open enrollment period for Medicare Advantage. I'm talking about Medicare Advantage if you're in one of these plans, because it gives you an option here. If you have a Medicare Advantage plan that you signed up for in October, November, you actually have you have January, February, and March, the first quarter of the next year, which you can make one more change. It's kind of a backup. So let's say you enroll in a plan and then you realize for some reason, oh, this is not what I wanted, or I wanted that plan over there. My doctor doesn't. It could be any reason you want. You have one more chance to change in the first quarter of the year. So it's kind of a backup. And then after that, after March 31st, for most cases, you keep your plan the rest of the year, and if you decide you wanted to change the following year, you can. So it's that repetitive every year.
So would that include a supplement, like if you had an Advantage plan, and you decided, you had a supplement before?
Okay, you have supplement first.
Then you decided to try the Advantage plan.
Yeah.
And then you said, I think I like the supplement better. So can you do that at any time of the year, or can you do that just with any special options?
That is an awesome question. So in that case, there is a special election for someone that has a supplement. I'll use my parents as an example. When my parents got Medicare, they both got what's called a Supplement F, Plan F, as in Frank, which is the top of the line, right? It covers, it's the most expensive, but you have no bills after, right? It's also going away, right? Medicare said, well, we want everyone to pay something. They want everyone to pay a deductible. Medicare wants us all to like pitch in some kind of a cost. So, but anyway, my parents both got a Supplement F, and they had them for about 12, 13 years. The thing about Medicare supplements is they can go up, and they do tend to go up. The premium can go up with age, or the insurance company can raise the cost for the whole class. Like say, okay, for Supplement F in California, we realized we need to bump up the premium $5 for next year. So the cost has changed. So it worked awesome for my parents because they traveled between two different states. They never had to worry about a network, right? Because the supplement, you just go to any Medicare available doctor. It was an excellent fit. After about 12 years, they were starting to say, oh, we're paying between the two of us $500 a month for the supplement. It's getting expensive. Plus they had to have a drug plan in addition, another $20, $30 a piece. So, and they weren't traveling as much. So I like their example because it's kind of, it makes sense of who might be interested. So when they stopped traveling as much and they didn't want to pay that amount of money, they both switched over to a Medicare Advantage HMO in the city they lived in Tampa, Florida. Their premium monthly went from $500 to $0 because that HMO had no monthly premium and it had drug coverage already built in. At that point in their life, it was perfect because the doctors that they wanted to see were in the network and they liked all the additional benefits. My mom used the gym membership and went to the gym for free, and she still does. So in their case, it worked, but it's two very different scenarios, right? I mean, if you really don't want to be stuck to a network, you probably don't want most Medicare Advantage plans. But if your providers are in that network, you like the benefits, and you're more sensitive to cost, it might make sense. And so that's why I use them as an example. Does that make sense? Oh, I didn't answer your other question. So in their case, this is what they did. They got to the point where they said, we don't want to pay that amount anymore. We don't feel like we're going to get the value of that between $500 and $600 a month just for the premiums. They needed to wait until the annual enrollment period so they could enroll into that Medicare Advantage plan, and then they cancel their supplement. Now, what you get in that case is Medicare allows you a 12-month period where during that 12 months, at any point in that 12 months, if you decide, I'm starting to miss my supplement, I think I'd like it back, you can go back. You have one chance to do that in the first 12 months. So it's kind of a nice safety net where you do have an option to go back if it's not what you wanted. That's an awesome question. Yes?
Speaking of, I didn't ask a question, I have one question with another. First is, if you're on one of these plans and then you suddenly can't pay, what happens for a year, you have a tragedy in the family,
Mm-hmm.
you can no longer pay that amount, you're bankrupted by your medical costs, can you switch to a cheaper plan, or you just thrown out of Medicare altogether?
If you stop paying, usually after about 3 months or so, the plan will drop you.
So you get dropped out of Medicare too?
No, you'd be, so like if you're saying, so like if it was a supplement or a Medicare Advantage plan, they'll typically, after about 3 months of non-payment, they'll call you, they'll send you letters, they'll drop you from the plan. You'd be back on original Medicare.
And are you stuck that way then, or?
You'd have to wait until the next annual enrollment period to re-enroll if you wanted
Because
to.
as you know, in this lousy country, people do go bankrupt from medical bills.
You can, but if you're on a supplement or Medicare Advantage plan, the likelihood of going bankrupt is pretty small because there's protections there.
Okay. The other question I had, you said about area and travel. If you're largely traveling within the state, can you get plans that are advantage plans that do cover the entire state?
Most plans are county-based, but if you're traveling, every plan has to cover you for urgently needed care or emergency care, regardless. So if you're traveling and you don't feel well and you think, I don't want to
It's
do
got to
it.
be a little bit of trouble because you see this sister and the rest of the family are in the old county here in Alameda.
Oh, yeah.
County.
There's-
They may not stay in Alameda County. I may
Right.
change to see, Alpine County.
Right, no, that's not a problem. I can use my mom as an example again. She lives in Florida. When she comes and visits us, there's been a couple times she's gone to a walk-in clinic. We just found the closest one because she wasn't feeling well and just wanted to be seen. And she just had a small copay for that. So the plans have to cover urgent and emergency care
What
when you're
happens if you
traveling.
permanently move mid-year?
Oh, you have a special election to pick a new plan in your new location.
Yeah.
Yeah, there's more flexibility than what there used to be as far as that goes. All right. Plan, I'll be quick on this. This is too busy of a slide. Medicare rates all of these private plans. All right, they give them a star rating. 5 stars the best, and it goes down from there. So it doesn't, I don't know how much of it we would notice from our end all I can tell you is that the higher the star rating, the higher Medicare has ranked that plan for how they manage their business. So if you're looking at a Medicare Advantage plan, they're always supposed to tell you what their star rating is so you have an idea, right? And plans that are not at least 3-star, their contracts are not renewed if they don't bring that star rating up within 2 years. So it's kind of a safety thing where Medicare's looking over their shoulder and going, hey, we need to meet certain metrics. All right, so those companies that get Medicare contracts, they have to follow Medicare rules. This just shows over time, private enrollment or in these Medicare Advantage plans since they came out has been steadily increasing. Which I don't think is a surprise, it's the nature of plans figuring out how to make these plans work and how to make them attractive. And when you look at the country as a whole, this kind of shows you, so here's California. About 40% of the people, the Medicare beneficiaries in California have a Medicare Advantage plan. I would have guessed that even if I didn't look at a map, because they tend to be the most popular in urban areas where there's a high concentration of doctors, hospitals, big networks, right? It just makes sense. If you live in a place where you have access to doctors, then it becomes a little bit more interesting to you. If you're in a rural place, you can see some of the states in the upper Midwest, if doctors are way spread out, that means that networks might be smaller. Well, then you may end up wanting a Medicare supplement because then you don't have to worry about a network, right? So it's not always the case, but you can kind of see that as far as where population is distributed. All right, Part D. So with Medicare, with these Part C and D, the ones that are offered through private insurance, an important thing to know is this: Medicare wants everyone every Medicare beneficiary to have a Medicare drug plan. And they don't care where you get it, they just want you to have a plan. So your Part D coverage, you can get it all by itself and get a plan that all it covers is prescriptions, and that way you can continue to use original Medicare or Medicare Supplement, or you can get it already bundled in with the Medicare Advantage plan where the drug coverage is bundled in. To Medicare, it doesn't matter, they just want you to have it one way or another, because they will penalize you if you don't take it. And honestly, it makes sense to take it because the benefit to a Medicare drug plan is pretty significant. So even if you're not taking any medications at the time of turning 65, you probably still at least get a basic plan to protect yourself, because the coverage through Part D is very significant. It's hard to believe that prior to, what was it, 2004 or 5, somewhere in there, Medicare didn't cover any drugs at all. At all. And back then, there were a lot of stories about people having to choose between groceries or medicine. It was pretty serious. Fortunately, that's been alleviated substantially because the Part D drug coverage is pretty extensive, and it's been getting better every single year. And I'll show you how it's getting better. So typically, drug plans, Medicare does not have their own, right? They have a template, and insurance companies put together a plan according to the template, or they can add, but they can't take away. Yes.
Cost of medications and covered medications.
So here's the key. Covered medications, every drug plan is going to have their own formulary. There's no standard formulary across the country. So when considering a drug plan, I would tell you to do this. If you're comfortable with the computer, go to medicare.gov, and it allows you to search by putting in, you can actually put in your prescriptions, and it will, by your zip code, it will show you, oh, okay, if that's what you take, here's what your costs are estimated to be according to the plans where you live. And it makes it like that to try to pick out a plan that will best benefit you. Because each company is going to cover things slightly different.
Are there any built-in limitations to them? We know Big Pharma is a big whatever, overcharging people. Is there any limitations on Medicare?
The limitations are, the prescriptions, well, the limitations are that insurance companies are, with your plan, you're going to pay a set copay for most prescriptions. So you'll already know in advance. That's why I would say go to medicare.gov and run that calculator, because they can't change it. When their copays are set for Medicare, that has to be their copay for the whole year. It's amazing. These Medicare plans are so much richer than what most of us have ever seen in the working world. Like, I would save so much money if I had one of these plans for myself and my family.
Trying to say is, you know how they bumped up the price of a vital heart medication or
Right.
7,000%.
Right.
Because Geek Boy decided he needed a new yacht.
So, yeah, but the thing is though, with these plans, if the prescription gets too costly and the plan can't float it, they'll drop it from the formulary and they'll add in an alternative from the same type or set of medication. So, but the cost that you're talking about, that happens if you have no insurance, or it could happen if you're on individual insurance, not on Medicare.
Okay, so you're not going to get to charge outrageous prices for drugs. So
No, there's set copays.
Bills to keep
Right.
them alive.
So how it works is this. If anyone ever, just by show of hands, I'm curious, has anyone heard of a coverage gap? Does that sound familiar? You ever heard that?
Donut hole.
Or donut hole? All right. That's part of what used to be, or it was part of the original Part D. It's almost gone now. There's actually not the same type of coverage gap as there used to be, and I'll show you, it's gotten progressively better. So, actually, I'm sorry, go back. So with any drug plan, they have these 3 levels, right? There's level 1, your initial coverage, level 2, coverage gap, and then level 3, catastrophic coverage. It works like this. With your initial part, you may or may not have a deductible, and then you pay your copays, all right? And for this current year, your initial coverage gives you help for the first $3,820 of prescriptions. So if your prescriptions are under that, you'll never even get out of level 1. But let's say you do. Let's say your prescriptions end up costing more than $3,800. Well, what happens? Then you fall into the donut hole or the coverage gap. But you don't pay 100%. You pay 25% on brand name drugs, and you pay 37% on generic drugs. So you're paying a portion. It used to be that you paid 100%, and that's why it was called a donut hole. You paid 100% in there, not anymore. All right, and that's actually getting better. In 2020, it's going to be you pay 25% for generic or brand. What the federal government did is, bless you, they're actually forcing the manufacturers to kick in a 70% discount on the drug when anyone falls into that category. So, and then the plan will pay a little bit. So the coverage gap has changed dramatically. It's so much better now than it used to be. Catastrophic kicks in if someone has had $5,100 worth of prescription costs, okay? At that point, Medicare says, okay, now you're getting into a really high level of prescription costs, now we're going to really step in. From that point on, if someone has costs of $5,100 at the pharmacy, after that, they'll pay 5% on their prescriptions the rest of the year. And the plan and the manufacturer will kick in the other 95% discount. So it's pretty significant. That changes lives. I actually saw that happen a lot for folks that were on incredibly high cost medications that sometimes in March or April, they would have already gotten through the coverage gap. So, which is still significant, but then the rest of the year, big help, right? They're paying 5% the rest of the year. So this has been getting better. Okay, last joke. I just got my bill for my prescriptions. Now I know why pharmacists work behind those thick plexiglass windows. All right. Oh, this is kind of showing what I was just talking about. Back in 2010, if you hit the coverage gap, you paid 100% of the cost of your prescriptions in the coverage gap. Over time, it's been dropping. So it's been one of those things that I was very happy to see that regardless of administration change, they kept on the same track of lowering. So by 2020, by next year, the coverage gap is actually equivalent, is 25% of the cost instead of the 100%. So that's been getting better over time, thank goodness. It's better protection. All right, any other questions? I went a little longer than I thought, but you had awesome questions. I wanted to answer them. Any final questions?